This recorded lecture will be going over Chapter 31, Pain, Comfort, and Sleep in the Fundamentals textbook. Pain is a feeling of discomfort strong enough to be intrusive and to affect or interfere with your normal activity. This can be experienced by the majority of the patients at some time during their healthcare experience. Many medical conditions, ranging from a headache to a myocardial infarction, such as a heart attack, can cause pain. Fever will cause generalized discomfort. Cancer, infection, fractures, cuts, and abrasions, indeed almost all illnesses and conditions, can be accompanied by varying degrees and types of pain. There is no accurate objective measurement of pain. It can only be assumed that patients will experience pain based on their diagnosed condition. Experts in the field do regard pain as a condition rather than a symptom, and ideas about pain and its management are changing. The approach to pain control has changed. The establishment of pain assessment and treatment standards and the expansion of pain management options are two factors that are contributed to these changes. The Joint Commission recently clarified their standards in effect related to pain and the focus on the patient. Their revisions include focusing on both the pharmacologic and non-pharmacologic methods, in addition to the benefits and risks to the patients when deciding the most effective pain management strategy. The standards relative to direct patient care state that patients have the right to appropriate assessment and management of their pain. Pain is assessed in all patients. Patients are educated about pain and managing their pain as part of the treatment as appropriate. The discharge process provides continuing pain care based on the patient's assessed needs at the time of discharge. Pain assessment is performed along with each assessment of vital signs, and pain is considered the fifth vital sign. Documentation of findings must occur. There's also an increased use of non-pharmacologic methods of pain relief, such as biofeedback, distraction, guided imagery, massage, and relaxation techniques. A fentanyl patch is one way of controlling chronic pain. Pain is defined as a feeling of discomfort, distress, or suffering caused by a stimulation of nerve endings. Acute pain is often a warning of potential or true issue damage, and it allows the sufferer to withdraw from the source or to seek help in relieving symptoms. Pain is transmitted to the brain through the nervous system. The gate control theory was first described by Melzack and Wall in 1965. Pain transmission is viewed as being controlled by a gate mechanism in the central nervous system. Opening the gate will allow transmission of the pain sensation, and closing of the gate will block the transmission. Several ideas that affect nursing practice are part of the gate control theory. This includes that the gate can be opened by activity in the small diameter nerve fibers from things such as tissue damage. Activity in large diameter nerve fibers will be required to close the gate. Brainstem impulses caused by a high sensory input will close the gate, whereas a lack of this input allows the gate to open. This can be a reason why people who are bored or lonely will experience more intense pain than when they are occupied or distracted. The cerebral cortex and thalamus will play a role by opening the gate with impulses originating from an increase in anxiety, or closing it with impulses originating from a decrease in anxiety. Endorphins are endogenous, naturally occurring opiate-like peptides that will reduce or block the perception of pain. Like morphine, endorphins will attach to nerve endings and opioid receptors and then block a pain transmission. Determining the type of and intensity of pain the patient is experiencing will help you select methods that will relieve their discomfort. Treatment decisions should be based on the assessment that considers a variety of all factors. You can see these different factors in the concept mapped on page 607. Acute pain is usually associated with an injury, medical condition, or surgical procedure. It is of short duration, lasting a few hours to a few days. Medical conditions causing acute pain can include pneumonia, sickle cell crisis, angina, herpes zoster, inflammations, infections, and blockages. The patient can be agitated or restless and may protect their painful area by splinting or supporting the area. Acute pain can worsen in the presence of anxiety or fear. The cause is usually easily determined, and the pain is typically well controlled with analgesics, surgery, or other techniques. Once the cause is removed, the acute pain will be relieved. Chronic pain can continue for months or possibly even years. Chronic pain is associated with ongoing conditions such as arthritis and back problems. The limitations imposed by chronic pain can cause long-lasting psychosocial effects on the patient due to necessary changes in their lifestyle. An increased heart rate, blood pressure, and respiratory rate can be seen with acute pain. These will often be absent in your patients with chronic pain. A combination of pharmacologic and non-pharmacologic treatments is recommended to alleviate chronic pain. Nociceptive pain involves injury to tissue in which receptors are called nociceptors are located. Nociceptors can be found in skin, joints, or organ viscera. This type of pain involves 4 phases. The transduction phase begins when tissue damage causes the release of substances that stimulate the nociceptors and will start the sensation of pain. The transmission phase involves movement of the pain sensation to the spinal cord. Perception then occurs when pain impulses reach the brain and the pain is recognized. Modulation occurs when neurons in the brain send signals back down the spinal cord by the release of neurotransmitters. Treatment of nociceptive pain can be directed toward one or all of the 4 phases. Non-steroidal anti-inflammatory drugs, or NSAIDs, will work by blocking the production of substances that trigger the nociceptors and the transduction phase. Non-pharmacologic treatments such as distraction and guided imagery can be effective during the perception phase. Neuropathic pain is usually associated with a dysfunction of the nervous system, specifically an abnormality in processing sensations. Diabetes, Guillain-Barré syndrome, multiple sclerosis, cancer, human immunodeficiency virus, and nutritional deficiencies are examples of medical conditions associated with neuropathic pain. Analgesics and opioids alone usually do not relieve neuropathic pain. Neuropathic pain is sometimes managed with common analgesics, such as those in the NSAID family, but also increasingly managed with adjuvant medications such as tricyclic antidepressants, anticonvulsants, and corticosteroids. Phantom pain occurs after the loss of a body part from amputation. This patient can feel pain in the amputated part for years after the amputation has occurred. If this cannot be controlled with conventional methods, pain can be controlled by continuous electrical stimulation from electrodes surgically implanted in the thalamus. Pain is whatever the experiencing person says it is, and it exists whenever the person says it does. In other words, only the patient will know what hurts, how much it hurts, and the interventions need to be based on their patient's own assessment of the degree of pain and their need for pain relief. One of the most difficult aspects of pain management is the assessment of pain and the evaluation of the effectiveness of our interventions. Cultural background will influence how people show their pain. Care needs to be taken to ensure that adequate pain management is provided. Observable indicators of pain would include moaning, crying, irritability, inability to sleep, grimacing or frowning, restlessness, and a rigid posture in bed. Other detectable signs of pain can be an elevation in blood pressure, heart rate, and respirations, or the presence of nausea and diaphoresis. Some patients may perceive pain to be less than or greater than what you may have seen before in the same condition. For some patients, it can be difficult to describe and tell how much pain is present. On page 609 in Table 31.1, you can see some helpful descriptive terms of pain. Be aware of any communication barriers that can prevent the patient from adequately describing their pain to you. Various pain scales are available to assist patients in communicating their pain level. A numeric scale is often used to help the patient rate their level of pain, with 0 being pain-free, and 10 being the worst pain imaginable. Your textbook says the worst pain imaginable. I like to ask my patients the worst pain ever. You can imagine the most crazy, amazing things. I don't want to know what you imagine it to be. I want to know what you've experienced it to be. So rather than saying, tell me your level of pain 0 to 10, with 0 being no pain and 10 being the worst pain you can imagine, well, you can imagine whatever. Instead, 0 to 10, with 10 being the worst pain you have ever felt. People can quantify that. They're going to sit back, they're going to say, okay, when is the worst type of pain I've ever felt before? They're going to remember that. Then they're going to say, does this hurt as much as that? That's going to be a much more accurate representation of their pain compared to whatever they can imagine up in their creativity. So I don't like that. Always say worst pain ever. Children, as well as some adults, may find a numeric scale difficult to use. In these instances, we can use picture scales, such as the Wong-Baker FACES, which can be seen on page 609. The face, legs, activity, cry, and consolability, or FLAC scale, can be used for pre-verbal children or non-communicative patients. The FLAC scale should be used on children ages 0 to 3, and we know that the Wong-Baker FACES scale is appropriate for patients 3 to 8, and after the age of 8, it is appropriate to use the 0 to 10 numeric scale with our patients. This is our 0 to 10 pain scale. Again, not worst pain imaginable, worst pain ever. You can see this on page 609. And then again, our Wong-Baker FACES, which you can also see on page 609. Now you can either ask your patient to point to the face that they feel like, or if they're just, very overstimulated at the moment, you can just look at their face and pick the one on the scale that they most look like. So either one of those methods would be appropriate. For the confused patient, you want to use nonverbal cues that pain is being experienced. These cues would include restlessness, rocking, pacing, rigidity, guarding, wincing, crying, grimacing with movement, new inability to sleep, hypersensitivity to touch, withdrawal from usual contact from others, moaning, and grunting. And it would also be appropriate to use the PAIN-AD scale for that type of patient. The plan of care needs to include pain assessment and management. The patient should assist with setting goals. Goals should be realistic. A patient with a chronic condition may not be pain-free, even with the use of analgesics. Medications or treatments that prove effective for one patient may not relieve the symptoms as well for another. Monitor respirations closely in any patient receiving opioids. The use of non-medicinal methods of pain control can greatly reduce the amount of medication needed. And over the next couple of minutes, we'll be going over various non-pharmacologic methods of pain control. The first is going to be transcutaneous electrical nerve stimulation, or TENS. This uses a small electrical stimulator and attaches electrodes to block pain. This therapy is available in high-frequency and low-frequency stimulation. The electrodes are placed on the skin around the area of pain. The patient can then control the intensity and interval of the current with dials on a stimulator. The use of TENS does require a medical order. Occasionally, a patient will not tolerate the TENS stimulation very well. If this is the case, just discontinue the treatment and then notify the primary care provider. Percutaneous electrical nerve stimulation is a treatment that has shown promise for relief of lower back pain, such as that caused by sciatica, and for relief of some severe headaches. Binders are cloths wrapped around a limb or part of the body. These are effective in relieving pain associated with strains, sprains, and surgical incisions. They can support the surface and internal tissues during movement, coughing, and other activities. A brace is a device used to immobilize joints. It's stiffer than a binder and promotes healing by limiting movement of the joint. The application of heat or cold, or the alternate application of the first one and then the other, can often soothe or relieve pain from muscular strain or overwork. It's also effective in reducing pain associated with healing tissues. The use of heat-producing equipment can require a medical order. Remember that the very young and very old patients have skin that is more sensitive to heat damage. In addition, patients with altered levels of consciousness, impaired movement and feeling, or poor circulation may not be aware when something is too hot for them. These patients can suffer severe burns in a short period of time. All patients should be closely monitored if any heat applications are being used. Cold is particularly helpful in reducing swelling and can be effective in calming muscle spasms and reducing the pain in joints and muscles from a variety of causes. Cold is most frequently applied in the form of cold or iced compresses. Some patients have a poor tolerance for cold treatment, so be alert to the patient's response when using any cold applications. Occasionally, patients will have an increase rather than a decrease in pain when their ice is applied. To prevent any skin damage, ice should be in contact with the skin for only a few minutes at a time, under direct supervision. Ice packs should be applied with a towel or other barrier between the pack and the skin and should not be left in place for more than 15 to 20 minutes. If a patient complains of cold with ice application, remove the ice and discontinue any further treatments. Explain that not all patients are relieved by cold application to pain, and that's okay. Relaxation or tension release is helpful in reducing pain and will allow the patient to obtain greater relief from their pain medications. Relaxation is a physical technique that involves conscious relaxation of muscle groups. Before beginning, make the patient comfortable in a quiet and darkened environment. Instruct the patient to first tighten and then release the muscles. Initially, encourage the patient to pay close attention to the difference in the feeling of tension versus relaxation. Have the patient begin by tensing and relaxing, or just relaxing, the toes and the feet, and then the ankles, calves, knees, thighs, lower abdomen, upper abdomen, shoulders, arms, hands, feet, neck, face, and head. Biofeedback is a specialized relaxation technique that uses a machine to measure the degree of muscular skin tension with skin electrodes. With this immediate type of feedback, the patient will learn to use their relaxation techniques or imagery effectively to decrease their tension. Distraction will assist the patient in focusing on something other than their pain. Watching television, listening to the radio, playing cards or a game, conversing with friends or volunteers, reading, using a computer, or even thinking about something else can all serve as distractors. Guided imagery and meditation. These methods will differ from relaxation in that they are mental rather than physical techniques. In guided imagery, which is verbally guiding the patient to imagine something, this can be used for pain control. Patients should be assisted in forming mental images of a pleasant environment where they're comfortable and happy, like a favorite vacation place. Patients undergoing painful procedures, such as a bone marrow aspiration, can learn to use imagery to leave their procedure mentally and go somewhere else while it's occurring. Be sure to see the patient education box on page 614, Pain Control Through Guided Imagery. In preparation, you want to assist the patient to a comfortable position, lower the lights, and eliminate any distractions. Close the door and post a note on the door asking not to be disturbed. Read the imagery script to your patient. Read slowly in a soft but easily heard voice. Pause frequently to allow the patient to form mental images. The script can be changed to incorporate a place or specific sensations to that patient. Take a look at the imagery script, and after the imagery experience, allow the patient to share with you if desired. Also accept that some patients just won't want to share, and that's okay. Meditation is focusing on an image, thought, breath, or awareness. This can provide a similar relief from painful stimulation, but it relies on the use of a focal point rather than the mental creation of an alternate environment. During meditation, individuals will focus on a visual point, a sound, a repeated phrase, or the pattern of their own breathing. Music can be used alone or as a source of distraction from the pain. It is frequently used effectively in conjunction with other methods as well. Hypnosis is a therapeutic suggestion that involves inducing a trance-like state of focusing and relaxation techniques, and then you give the patient suggestions that can be helpful after their return to an alert state of consciousness. Massage has long been used to induce relaxation and bring relief from muscle and structural pain in the body. Long, firm strokes, softer circular strokes, and gentle pounding will stimulate circulation, relax muscles, and increase a patient's sense of well-being. Conditions such as healing surgical wounds or inflammation of the tissues or vessels can preclude direct massage to an area of pain. When pain medications are not ordered for patients experiencing pain, when pain medications are ordered for patients in pain, you're responsible for monitoring the patient's pain level and administering the medication as it's ordered. The patient also needs to be monitored for effectiveness of the medication after the administration. The period for reassessment will vary depending on the route of administration. The 4 basic categories of medications for pain relief are non-opioid pain medications. This category includes NSAIDs, cyclooxygenase 2 or COX-2 inhibitors, narcotics or opioids, and adjuvant analgesics. An analgesic is a pain-relieving medication, and you can see categories of analgesic medications on page 615. Pay attention to the non-opioid analgesics, including NSAIDs. These are so very commonly used for pain control. See that the examples of prescription NSAIDs includes ibuprofen, prescription dose, naproxen, and indomethacin. Topical medications can provide for relief of muscle or joint pain. Medication patches, such as fentanyl patches, will allow the analgesic medication to be absorbed slowly through the skin. Look at the safety alert in the red box on page 616. Signs and symptoms of a fentanyl overdose are shallow respirations, extreme sleepiness, inability to think, walk, or talk normally, or feelings of faintness, dizziness, or confusion. If symptoms occur, remove the patch and clean the skin, and call the primary care provider immediately. Always remove or check any medication patches prior to any procedure your patient is going to. A pain medication patch containing metal needs to be removed before a patient undergoes an MRI scan. Otherwise, burning to their skin can occur. IM or subcutaneous injections of pain medication is usually used for severe pain and typically only for a short period. Medication given by this method has the advantage of lasting for several hours, but administration is painful and prolonged use can be detrimental to our tissues. IM injection will require careful technique to avoid any nerve injury. The IM dose given is larger than that given intravenously, and the length of time the medication is effective for is extended due to the slow absorption from the muscular tissue. IV pain medication can be given as a bolus. This is a concentrated dose given rapidly, as a slow push over a few minutes, or as an intermittent infusion or a continuous infusion. Patient-controlled analgesia, or PCA pumps, is a method that uses a programmable pump. The medication will come in a special cartridge or syringe, pre-diluted to an appropriate strength. This pump is then programmed to administer the prescribed dose each time the patient pushes a button, which limitations are then set on the pump by the primary care provider. The pumps are programmed by the RN or pharmacist. Within the limits set by the primary care provider's orders, the patient can choose how often to receive their medication. PCA has proven to greatly reduce patient anxiety about pain by putting the patient in control, and most patients will actually use less rather than more medication on their PCA pumps. Before caring for a patient with a PCA pump, it's important to understand how it is programmed. how the medication is inserted, and how the machine is locked to prevent anybody from tampering with the medication and the programming. Epidural anesthesia is a route of anesthesia where an anesthesiologist or nurse will place a thin catheter in the epidural space near the base of the spine and then connect a catheter to a small battery-operated programmable pump. The pump administers an opioid analgesic to the epidural space, either as a bolus followed by a continuous infusion or as repeated bolus dosages. This will be ordered by the primary care provider. This method is effective in controlling pain while allowing a patient to remain alert. Possible side effects from the opiate component of the infusion include respiratory depression, pruritus, nausea, vomiting, constipation, urinary retention, low pulse rate, and hypotension. Because of rare but potentially dangerous side effects, particularly respiratory depression, patients receiving epidural analgesia need to be monitored closely. This will often include placing them on an apnea monitor and pulse oximeter for the first 12 hours of treatment. The primary responsibility for caring for the epidural catheter will lie with the RN. The LPN monitors the patient's response to the medication. Patients with chronic severe pain can have small pumps implanted and attached to an intraspinal catheter in order to provide them with long-term pain relief. Frequent evaluation of pain control methods is, of course, important. As the patient's condition improves, various interventions, such as medication, might need to be tapered or discontinued. An important nursing action is to assist the patient in obtaining enough sleep and to maintain their health. Adults will need 7 hours of sleep per night. Sleep influences memory, mood, cognitive function, secretion of various hormones, immune function, body temperature, and kidney function. Adequate sleep also plays a major role in pain control. Being rested will increase pain tolerance and allow an improved response to analgesia. Both accidents and illness will increase in frequency without sleep. Normal stages of sleep will follow a course through 2 states: non-rapid eye movement, or NREM sleep, and rapid eye movement, or REM sleep. REM sleep is the time in which you have dreams and a period of high level of activity. NREM sleep is believed to be the time when the body is receiving the most rest. During this stage, your heart rate, blood pressure, and respirations will decline. NREM sleep is divided into 4 stages. The first is a transition stage. As a person falls into a light sleep, their muscles relax. In stage 2, the person falls into a deeper state of sleep. This stage will last 10 to 20 minutes. As stage 3 begins, the person enters a period called delta sleep, or slow wave sleep. This is named for the high voltage, slow brain waves that occur in this stage. Respirations and heart rate will slow in this stage, and the body becomes immobile. This deep stage state will last 20 to 40 minutes. And dreaming is very common. Stage 3 sleep is followed by the deepest stage of sleep, stage 4. During this stage, it is very difficult to arouse the sleeping person, and this stage lasts about 30 minutes. That is then followed by a period of REM sleep. And in that stage, this is where vivid dreams will occur. It lasts approximately 20 minutes. The amount of sleep somebody needs will vary from person to person, and the amount of sleep needed will change as we go through our life cycle. Newborns will require 16 hours of sleep per day. By age 1 year, the child is sleeping 12 to 14 hours a day. They will continue to need that amount of sleep until they reach their preschool age, and then the amount drops to 11 to 13 hours of sleep needed. School-age children will require 10 to 11 hours of sleep per night. Growth hormone is secreted during deep sleep in children and adolescents. Although adolescents need to get 9 to 10 hours of sleep a night, their internal clock usually will not trigger feelings of sleepiness until late at night, due to a natural shift in their circadian rhythm that occurs during that period in development. Most adults will require approximately 7 to 7.5 hours of sleep a night, but many get less than that. Sleep difficulties increase during middle age and can be particularly problematic for menopausal women. Older adults also tend to have what is called advanced sleep onset. This means that they go to bed earlier and get up earlier during their younger years. They can also nap during the day, and this will represent another shift in our circadian rhythm. Many factors can disrupt our normal sleep cycle. Working evening and night shifts. Workers who change shifts during the month have an even more difficult time adjusting in order to get enough rest. Students will often spend nights studying. Travelers can suffer from jet lag. Several hours of sunlight exposure can help reset your internal clock. Lifestyle can affect your ability to sleep. Caffeine, nicotine, and alcohol consumption can all interrupt your normal sleep patterns. Look at the clinical cues on page 621. If a patient complains of trouble sleeping, ask about any beverages that are consumed after 3 p.m. Many drinks contain caffeine, including carbonated beverages, and it's important to check all ingredient labels. Regular exercise can help a person sleep, but exercise too close to bedtime can be overstimulating and keep you awake. Taking a nap late in the day can also disrupt nighttime sleep and should be avoided if an individual suffers from insomnia. Instead, encourage exercise in the mornings for a restful sleep. Stress and illness will also affect the sleep. Illness or discomfort can prevent a person from sleeping well. Environmental factors such as a room that's too hot or cold, too noisy, or has ambient light will also affect sleep. Patients in the hospital often have increased interruptions of their regular sleep period due to hospital routines that cause noise or require lights, because of the need to be awakened for medications or treatments. Postoperative pain can also be a source of sleep disturbance in the hospital. Disorders of sleep can interfere with a person's quality of life and affect their health. People with sleep disorders should be treated by a healthcare provider if lifestyle changes or relaxation techniques fail to increase their quality of sleep. Insomnia is a difficulty in getting to sleep or staying asleep at night. This can be short-term, lasting only a few nights, or chronic, lasting maybe a month or longer. Restless leg syndrome can awaken the patient frequently, with a persistent need to move their legs. SCDs are an intervention in the hospital that can help with this condition. Chronic insomnia can be the result of an underlying medical, behavioral, or psychiatric problem, and it should be thoroughly investigated by your primary care provider. Sleep apnea is a condition in which the person stops breathing for brief periods during sleep. There are 3 different types of sleep apnea: obstructive, central, and mixed complex. Obstructive apnea is the most common type. This is caused by a relaxation of the soft tissues, which allows partial to total obstruction of the airway. These individuals will often not remember waking up, even though it will occur multiple times throughout the night and even multiple times per hour. Central apnea is caused by a failure of the brain to communicate with the respiratory muscles. This results in a cessation of breathing with no obvious or observable respiratory effort. This is much less common than obstructive apnea. Mixed complex sleep apnea is, as the name implies, a combination of obstructive and central sleep apnea. Obstructive apnea can be treated with a continuous positive airway pressure or CPAP device. The devices, or a BiPAP device, which is a bi-level positive airway pressure. These devices will use a small compressor in order to maintain airflow via a mask or nasal prongs and should be used while the patient is asleep. If a device cannot be tolerated, surgical procedures can be performed to correct an obstruction. Snoring or harsh sounds that accompany breathing during sleep are caused by a vibration or obstruction of the air passages at the back of the mouth and nose. This can occur due to a result of poor muscle tone, excessive tissues, or deformities such as a deviated septum. The mild snorer should exercise to develop good muscle tone and lose weight if needed. Remember that snoring can be a symptom of airway obstruction and should always be taken seriously. Narcolepsy is a sudden onset, recurrent, uncontrollable, brief episodes of sleep that occur during the normal hours of wakefulness in a well-rested person. These sudden sleep periods can occur at any time, and they can last from a few seconds to more than 30 minutes. Symptoms typically begin by the age of 25 and can start as excessive daytime sleepiness. Diagnosis of narcolepsy is through clinical evaluation, sleep logs or diaries, and the results of sleep laboratory tests. Always conduct a thorough history of any sleep-related problems that the patient has had. Encourage our patients with sleep difficulties to keep a sleep diary. They should record the time that they went to bed, when they woke up, and any time they woke up during the night, their usual diet, and any and all medications and supplements taken, including any sleep aids. When planning, pay attention to the amount of sleep that the individual patient needs. Helping a patient adjust their lifestyle and bedtime habits can allow them to have a sufficient amount of sleep. Some tips include avoiding caffeinated beverages for 6 hours before bedtime, eliminating alcohol or nicotine for 2 hours before bedtime. Encourage the patient to exercise regularly, but not immediately before bedtime. Exercising in the morning would be a better routine. Patients should try to establish a routine time for going to bed and getting up, and avoid taking any naps late in the day. Going to bed hungry or overly full can also interfere with your sleep. Reading, playing, video games, watching TV, or using a computer in bed should always be avoided. The bed should be used for sleep, not watching TV or playing on the phone. Patients in a healthcare facility are especially prone to any environmental disruptions. The use of earplugs or white noise machines can help block out noise. Many patients will sleep better if they have a favorite pillow or blanket from home. Do not wake patients unless absolutely necessary. Attempt to cluster procedures such as vital signs and dressing changes in order to avoid waking a patient repeatedly. Medications such as sedatives and hypnotics are sometimes prescribed to promote sleep. They should only be used for a short-term time. When documenting, always record the amount of time that the patient has slept, the number and types of interruptions, and the patient assessment of their quality of sleep.